We're going to call the administration meeting, committee meeting to order. Can we get a roll call, please?
Chair Burning.
Present.
Vice Chair Counter.
Present.
Supervisor Fiedler.
Present.
Supervisor Long.
Present.
Supervisor Shirley.
Present.
We have a quorum.
Excellent. Are there any changes to the minutes? Any changes to the minutes? Hearing none, we'll consider the minutes approved. Public comment. Is there any public comment? Hello, Barb.
I think it's okay, it's on. Barbara Kruger, I'm here as a director of the Deer Park Public Library and chair of the County Library Planning Committee. I'm here to address the resolution disbanding the County Library Planning Committee. It's on the agenda. Yes, the last meeting of the Planning Committee was in 2020, November of 2021. I think Paul was there. And that was to trigger the process of updating the county plan of library service. It's never easy to admit mistakes, but as chair of the Library Planning Committee, I have dropped the ball for additional meetings. Things happen, and you can have the best of intention. Anyway, the draft of the plan is ready, and how it's prepared is a number of the library directors get together to review the existing plan, create a draft. And it is ready to be reviewed by the county, all of the county library directors, who actually have a meeting scheduled for Tuesday, May 28th. And that will be one of the items on the agenda. And that meeting was planned before we knew about the resolution to disband the County Library Planning Committee. Once that's done, then we take it back to the Library Planning Committee. A public hearing can be scheduled, which is followed by the Administration Committee, reviewing it, approving it, then by the County Board of Supervisors. The Plan of Library Service and the County Library Planning Committee work together. It serves, the County Library Planning Committee serves as a representation of residents of the county with the public members, the ad hoc members, with the county supervisors who are on the committee, and then by the library directors who are on there. It was formed to represent a cross-section of the county, to truly represent all areas of the county, not just higher population areas, and that was included in the description of the county plan, planning committee. So my comment at this time is the dissolution of the library planning committee should not be based on my having dropped the ball. Once the plan is completed, I'm planning on resigning from the committee, and then other people can take the place and keep the next generation going forward. So that's my comment. Thank you.
Thank you, Barb. Are there any other comments? Any other comments? Any other comments? Seeing none, we'll move on to our business items. Number one, consideration of reclassification of Compass Assessor Treatment Court Case Manager from grade 17 to grade 18.
So, as stated, this was pretty much just kind of an error on our part, and we missed it along with the department head. The original placement of this really should have been in grade 18 for internal equity. It's always been placed in the same grid as the pretrial case manager. Their positions are very similar, and so it's just to kind of correct that misplacement when we created the new wage grid.
Is there a motion to bring this to the floor?
I so move.
Okay, so the motion is to consider, or is to reclassify Compass Assessor Treatment Court Case Manager from grade 17 to 18, correct?
Correct.
Okay, we have a motion and a second. Is there any discussion? Supervisor Long.
Financial impact.
Oh, I shut that off. Actually, it will be a decrease because when we moved, there's already an incumbent in that position. When we moved them to grade 17, they received the pay that was most similar to their current pay on the old wage grid. Well, we're not going to move them again and give them another increase because of the mistake. So they'll be placed at grade 18 where they originally should have been placed back in March, which actually is a 2-cent decrease in pay. So it's very similar, but it doesn't have any financial impact.
Saves us $40 a year.
Yeah.
Any further discussion? Any further discussion? Hearing none, all those in favor of the resolution signify by saying aye.
Aye.
Any opposed? Motion is approved. Business item number 2, resolution amending Personnel Policies and Procedures Handbook. Back to Audrey.
All right. This one is just kind of making some updates, some additional information for employees to better understand exempt timekeeping guidelines. So currently we do have, I believe it's 4 to 6 staff that are under a 1.0 that hold an exempt status. And so typically with exempt, right, you're not eligible for overtime hours, but that's going to begin at your FTE. So if you're a 0.8, you're paid a salary for 35 hours a week. And so any hours over 35 are not paid hours. And so it's to help them understand that as an exempt position, it's not just that you aren't eligible for overtime, but you're not eligible for additional hours over your FTE to be paid hours. So you may have to work those hours in order to get your job accomplished, but you're not going to be paid additional compensation for those hours. So we just wanted to spell that out in the policy so that they really fully understand that.
I'll entertain a motion to bring to the floor.
I'd like to make a motion. I would move to approve the resolution amending the Personnel Policies and Procedures Handbook.
We have a first. Is there a second? Second by Supervisor Fiedler. We'll open this up for discussion. Supervisor Counter.
Just for understanding on this, so if you, I talked briefly on this earlier, but if you have a situation where you have an employee and they're a good employee and you are, the workload that's being given is above and beyond what would normally, what you could accomplish in that time period, not knowingly you're assigning more than what, but they always are keeping up with it and spending the extra time. Do you have a way that you'll be able to compensate or deal with this for the future for that employee or reassign, or how would you address those situations just so that you don't lose a good employee because you're having them do things above and beyond?
Yeah, part of why we record exempt hours is from a management perspective, so we can evaluate when the work demand is exceeding a normal expectation. So, for salaried employees, it's expected that, they may exceed 40 hours in any given pay period. But if they're consistently at 60 hours all the time, and they say, I really need help, well, there's some data to justify that need. And so it's exactly the reason that we do it. Or if an employee comes back and has only been working just 40, they go, well, we need some extra help. Well, do you really? I mean, maybe this one over here is going to be a higher priority because the data backs it up. So the part of your question about giving them extra compensation, no. As a salaried employee, there is not a mechanism to give them extra compensation. But there is a mechanism to give them extra help if we can, and the data is supporting that.
Is there any further discussion? Any further discussion? Hearing none, all those in favor say aye. Aye. Any opposed? The resolution is approved. Number 3, discussion regarding the financial benefits of establishing an on-site employee health clinic. Ken.
Yeah, I'm going to introduce, Leif Larson. He's our employee benefits specialist. He's going to go over a case example for an on-site clinic and a little bit of background note. But this is an idea that the county is looking at of establishing an on-site or a near-site clinic. And we're really looking for feedback right now from you before we get to the point where we ask for any formal approvals. So introduce it to you and watch your reaction.
And I also encourage you guys to ask any questions as we go along. This is a discussion, so I want to make sure that you guys get your questions answered as we kind of go through the process. So what I kind of want to do, Ken said I'm going to walk through a case study, which I will, but I kind of want to lay the groundwork first around what exactly a direct primary care clinic is and how the county and our employees can kind of benefit from it. So a direct primary care clinic has been kind of, I've heard about it in the market for about the last 5 to 10 years. Really what it is that the employer sponsors a clinic. So basically we are paying the provider to administer healthcare services to our employees. The idea behind this is that we basically take the insurance company out of the middle. So we as the county would pay a certain fee throughout the entire year for our staff to have access to that clinic, but all the claims would basically be handled as part of that annual fee that we pay to the various clinics. No claims from the clinic would go through the health insurance. The impact to employees is that they actually would receive services for no or limited cost, depending upon the healthcare plan that they choose. So if they're on the traditional plan, they get unlimited free visits to the clinic throughout the year, along with labs and certain generic medications that can be dispensed out of the clinic. If you're on the high deductible plan, we are required by law to charge them something for that visit. So we kind of have the say as far as how much we charge them. It'd be $10 to $25 a visit is whatever we kind of deem is fair. That copay actually gets paid to the clinic and then gets routed actually back to the county. So really that employee basically would be paying the county for that copay instead of paying a healthcare provider such as what they would do currently. As I said, the county pays an annual fee to access or operate the clinic. So this would be on an annual basis. Well, I'll touch on the exact costs here in the next couple of slides, but that would cover any of the office visits. So if it's preventative, if it's, I'm a sick kind of visit, if it's an urgent care kind of visit, all those visits will be covered underneath that annual or monthly fee. Any costs for labs or medications would be passed back to us at cost through from the clinic directly back to the county. And it kind of pennies on the dollar that you would pay in a traditional healthcare setting. To kind of outline some of the advantages, both not only from the county's perspective, but also from the employee's perspective, I kind of highlighted it on the last slide, but there's lower out-of-pocket costs. By removing the copays and by removing the deductible effectively on the high deductible plan, our employees would immediately see lower out-of-pocket costs for any time they visit that clinic. There's also potential cost savings. The more utilization that we can drive through that clinic, the better off and more money the county will save in the future. The idea behind the clinic is to kind of, because we're setting that fixed cost, the idea is that we're kind of lowering that curve every single year where we would have an increase. And I'll show you a chart of where an example where that kind of worked here in the next couple of slides. Another big piece from an employee perspective is improved quality of care. So by taking the insurance company out of that picture, doctors don't have to answer to the insurance company around how they provide care. So really the focus shifts from the employee or from the insurance company as far as what they'll pay for as to the employee's care. And so all the providers that we talked to as we went through the investigation of this, the focus really is on making sure that the patient is living their healthiest and best life and making sure that all their questions are answered before they leave that clinic and not having to worry about any hidden fees or anything that might come out on their bill after the fact. Obviously, the advantage of doing a direct primary care or an on-site clinic is the convenience and that it's directly on-site. There is some inconvenience if you, say, work in New Richmond or you say work in Baldwin, because the idea would be that we would move the clinic downstairs in a space that we have as part of the new building in the new addition. But we'll kind of talk a little bit more about that as far as kind of what some plans are that we might have to kind of make that a little bit more convenient for our New Richmond and Baldwin staff. Last but not least is access to care. So I have 3 young kids at home. I am acutely aware of where I can get care after the hours of 4:30. There's about one place here in Hudson that you can get it at urgent care, or you're going to an emergency room. So the cool part about having the clinic and owning the clinic is that we can kind of have some say around when the clinic's open, and especially given that we have sheriff's office and 24-hour staff up at the nursing home as well. 9 to 5 may not be the best hours for everyone, so we can kind of have some say around when the clinic is open because we have that kind of vested interest and we have a little bit more say in that. As far as how the health plan can save money, I think about this kind of in 2 separate ways. One is in claims diversion and one is in claims avoidance. For claims diversion, those particular visits that you see listed there can immediately be diverted directly over to the health plan, or from the health plan into the on-site clinic. So anything that we are currently paying in the form for office visits, urgent care visits, labs, immunizations, all of those would be direct savings if we get those services handled through the on-site clinic. And from that perspective, it's really easy for this particular side of the fence to identify what our ROI would be, depending on the level of usage that we have. As I said, the higher the usage, the better off we are, the more money that we save. On the other side of the coin is claims avoidance, and this is a little bit more squishy, which really makes kind of finding that true ROI a little bit harder to determine, because ultimately there are a lot of ways that we can avoid claims by having the on-site clinic, but it's really hard to monetize that or figure out what exactly the ROI is that's tied to that. Couple of examples here. Less specialist referrals. So in the current traditional healthcare platform, you go into your primary care doctor. If you get some sort of diagnosis that's outside of their predetermined guidelines of what they can treat, they're going to refer you out to a specialist, whether you need that specialist visit or not. When you work with providers in an on-site clinic, they like to use the term that they work at the top of their license. So basically, it's not necessarily to their advantage to get that referral out to the specialist. They will do that if they think it's necessary, but ultimately it can result in less specialist visits if the certain diagnosis they can handle in-house, where they may not have necessarily wanted to in a traditional healthcare platform. They can also really help with steering to high-value providers. So if that person does need surgery, or they need an x-ray, or they need a CT scan, they can, working with the high-value providers or the cost-efficient providers in the area, they can help steer our employees towards that. Again, it's hard to monetize exactly how much savings that would be, but just to give you an illustration, if you get an MRI done at Mayo Clinic out in Menominee, a regular contrast MRI is about $2,700 is what gets charged back to the plan. If you get that same MRI done at Hudson, it's about $800. So just kind of being able to kind of steer folks to those cost-efficient providers can help us save on claims on the back end. I mentioned the finding care off hours. Again, if we're able to offer the clinic after hours, hopefully we can avoid some of those unneeded emergency room visits. When we worked with J Counter and looked at our claims, we had something like 71% of our current ER claims could have been handled in an office setting. So the more that we can have them run through an on-site clinic, giving them the access to care, really can help reduce our overall claims costs. And different providers and I'll kind of touch on the 2 different models that we looked at, but they also bring different things to the table. One of them has a medical weight loss program that they offer through their clinic. That's what they're kind of known for. Again, we all know that the more weight that somebody loses, the healthier they're going to be. How much If we lose that weight, it's a little bit more of an open question. So it's kind of a little bit squishy around how we kind of get at the ROI, but I did kind of want to illustrate the different ways that that an on-site clinic could help save us in claims cost. As we were going through this kind of process, we really kind of honed in on really two different models. We call them an on-site versus a near-site. And we have two different vendors that would sort of handle each side of this. An on-site clinic would be a vendor that's ran out of Indiana. They own and operate clinics throughout the United States. On the on-site, it would really be a ground up because we would basically be creating a clinic from scratch. We would have the clinic housed down here at Hudson. They do have some virtual options, but that would be the only location that we would have access to at implementation. The way that this works is as far as the money side is concerned, we would pay a contracted fee every year as far as how much they need to run the clinic. That's about $1.3 million to run the clinic on an annual basis. We have a contract on the table that allows for a 3-year contract, and then each year that 1.3 would increase at a 4% escalator each year. With the on-site model, it would be a private clinic, meaning that it would only be open to St. Croix County employees. However, we have explored the option of bringing in other public entities to kind of buy some of that capacity off of us to kind of help defray some of our costs. And there has been some organizations in the area that has expressed some interest, but again, we haven't pursued it any further, kind of given what you guys say. On the other side is a near-site clinic. So this particular vendor is well established within the Chippewa Valley as a direct primary care provider, and they already have locations in Menominee and Hudson as well. If we were to join them, they would have to expand their capacity here in Hudson, and they have actually expressed interest to move into our location downstairs. The way that this one works is we actually pay a membership fee. It's very similar to the operation, but basically we pay to have access to all of their clinics. So any of our staff could go to Menominee, any of our staff could go to Hudson, or use their virtual option that they run out of that Menominee and Eau Claire clinics. But we would have access to any one of those clinics that our staff could attend. So that kind of does help some of our Baldwin Highway staff because some of them could use the Menominee clinic as well as some of them could use the Hudson clinic. Obviously, we do have issues with New Richmond. I have been pretty open and honest on that piece. On the near site side of the house, they have said that they would look at potentially opening a limited hours clinic up in New Richmond to help facilitate our staff along with some of their other clients that they have in the area. However, they don't have enough people in the area to support a full-time clinic. So there's a little bit more variables and stuff that we'll have to kind of work through around potentially to move a clinic up in New Richmond. On the on-site side of the house, their solution was that they could drive a bus and have kind of limited hours up at our New Richmond locations periodically through, a couple times a week to kind of help service that group, but we haven't really got into super close details on how exactly that process would look. Sorry, I'm bouncing around here. On the near site side, yep. Yeah.
Sorry to interrupt, but
No worries.
just to clarify, so we're basically contracting with a vendor to operate the clinic, and it's not the county itself that's operating the clinic.
Correct. Yes, we would be working with a vendor that has experience. I will not be opening a clinic and running it myself.
Yeah, good, thank you. Can you touch on, maybe this is a little later in your presentation, but the liability issue, if there was some particular problems with the medical care, how does that work with the fact that we're contracting with a vendor?
So ultimately, all that we would be really doing in this case is kind of giving them the space to operate. They would be hiring the providers. I believe I'll have to double check on who owns the malpractice insurance because I think that's kind of where your question
They
is
do.
coming.
We would not have the
Yeah, I would
medical.
assume that would be there. Yeah. Basically, everything should run through them as far as the liability. I mean, if someone slips and falls in the parking lot, that would probably be our risk. But as far as anything that kind of happens from a medical side, it would be on the on-site clinic vendor's side. Any other questions from you guys before I kind of move on? All right. So the case study that I wanted to bring up to you guys is Chippewa Falls Area School District. So they were one of the earliest adopters in our area of those that were in the public space of a direct primary care clinic. They opened theirs in 2017. It's a private clinic, so it would be kind of more like our on-site model that I sort of positioned to you guys. But they do actually provide a very unique case study for us because they are very similar in a lot of ways to our St. Croix County population. Size-wise, they have about 1,400 people on the plan, which is basically very similar to what we have on our health plan. Additionally, they do have some location issues. So their clinic is located in downtown Chippewa Falls. They do have an elementary school that's about 17 minutes away from when I went to Google Maps. And about half of their staff actually live in Eau Claire, which is about 20 minutes away from the clinic. 20 minutes is kind of a key point for us because that's really how far New Richmond is and how far Baldwin is from Hudson. So that's kind of why we use that barometer. So about half of their staff is sort of outside of that 20-minute window, which again, ours would probably be a little bit higher than that, but again, it gives us a very good comparative group. And because they've had the clinic the longest, they also have the trend lines, which is what I kind of wanted to show you guys. So this is their actual medical spend. This includes not only what they're paying for the on-site clinic, but as well as what's at the claims that are actually hitting their medical plan. The top line shows an 8% trend line increase, which if you talk about what the kind of the community increases or what the average increase that most health plans have, it's anywhere from 7 to 10%. So we decided to split the difference and make it 8.5%. So that kind of shows what the average employer would see from a health care increase. Thankfully, we've been better in past years, but I thought it would be worth showing that 8%, which is what, again, we would normally expect to see. The bottom line actually shows their actual medical spend. The one thing I did want to highlight is the substantial difference between 2015-16 and 2016-17. They did double their deductible that year, so that's what accounts for the huge decrease. However, the important piece to see here is that the trend line is flat or decreasing that for all the years after that. After the clinic was opened, they are kind of leveling that curve, so to speak. The other thing that I wanted to mention too is that since they doubled their deductible in 16-17, they have not changed their health plan design or increased premiums in any way because of that trend line that you guys saw. This next slide, it shows the per member per month claims experience. So here in the benefits field, that's the best way that we look at claims is on a per member per month basis. It allows us to compare, groups of our size, say 1,400, with plans that are, say, maybe 70, because ultimately we can get it down to the same kind of variable. And again, you can kind of see that downward trend line after that 2017, 2018, which is when they opened that clinic. So these next few slides, the information you're going to see is the claims that actually hit the health insurance plan. So not necessarily what happened with the clinic, but this is the actual expense that the school district incurred to the health plan after the clinic rolled out. And you can still kind of see a pattern here that the trend continues to kind of trend downwards. It's even more pronounced on office visits. So the last one was preventative care. That would be more your annual physicals, that kind of stuff. The office visits here, those are going to be the I'm sick appointments, the I have a sinus infection, I broke my arm, that kind of thing. And again, those are where this on-site clinic can really start to drive those because, again, they have those expanded hours and things like that as well. Hospital admissions, it's worth notating on this that obviously the clinic can't control everything. However, again, the better quality of care that you can receive in the on-site clinic can help you keep out of the hospital, and I think that's what they're kind of trying to illustrate. Obviously, they had a really bad year in 2019 and 2020. Again, we had a bad year last year. It's going to happen. But the idea is that the more care that they can receive in the clinic, the less likely they are to land in the hospital. Labs, the interesting thing on this one that I thought was, so currently we have about $500,000 that we spend in labs a year. And if you look at the furthest bar on the left-hand side, that's basically about where they said they're at about $450,000 in labs. So this theoretically really could be us. Again, you can tell where I'm at on the clinic, I'll be honest. But, but again, you can see that downward trend. The more people that use the labs, again, it can make a huge impact going from 450,000 down to 100,000. And then this last slide just kind of compares the labs that were done in the clinic versus those same labs if they were done in a community or in a traditional healthcare space. And again, you can see that it's about 10 cents on the dollar as far as what those labs would actually cost the county, because again, those would be sent back to us at cost.
So that was the last slide of the presentation. Leaves available for questions. I guess I would point out, I guess the perspective I have and the dilemma that I have is that we're looking at 1 to 1.3 million per year, and it's probably going to be a 3-year trial that we do. So we're committing to $3 to $4 million of spend. And I can guarantee you in the first year, we're losing $500,000. When you look at the direct avoided cost, there's not enough directly avoidable cost to recoup all that. Where the savings comes in is, do you end up with a healthier employee body? Do you get enough people using the clinic that you get that flatlining of the expenses? So, will it save us money over the long run? I don't know. I know year one, though, cost me $500,000 more. That's how come I have pause. But that's where I'm looking for, is this something that you guys see as a long-term benefit, something that you're willing to invest in, or do you have concerns over it? This also doesn't include the build-out. So we have 1,900 square feet that we framed out with the Government Center Addition project. So we have a roof and a sand floor. And the doctor said that wasn't sanitary enough. So we would have to build that out. They did, I asked. So we do have to build that out. If you use our cost per construction on this project, that comes out to about $1.2 million. They said it was more like $500,000 to build out the 1,900 square feet. So I don't know, maybe some of you have some construction experience and be able to estimate what 1,900 square feet cost to build out from sand with walls and a ceiling already. But that's what we're looking at. So there is a construction standpoint too that you're investing that in, and that's not even in the payback. So feedback.
Are there any questions? Yeah, Supervisor Long.
So are there other examples of clinics that have been set up that have not been successful? I guess another way of asking that is, what's the downside other than the initial cost that we have to figure out how we're going to pay for?
Yeah. So I can speak a little bit because I know Supervisor Counter had actually mentioned this. This is one I wasn't aware of, but Washington County had one. In their case, it was a little bit of a different case that they had health partners come into their clinic and basically ran a health partners clinic out of their government facility. And that was not overly successful. I think it ran into COVID and things like that also didn't necessarily help that factor. And I think they also, they ran it like a health partners clinic. So if you were on a high deductible plan, you got billed like you were on a high deductible plan. As far as other organizations that have the clinics, I'm only really aware of success stories or incompletes, for lack of a better way to put it. So I know in Baldwin they have I think it's 5 different public and private partnerships. So I think the school district's involved, and some of the local employers there, they have a on-site clinic that they came together on, and that's been going on for a number of years and has been very successful from their side. Dunn County and Chippewa County have actually looked at direct primary care and have started a relationship, but it's only been within the last couple of years. So I don't know of one that necessarily failed, I guess, which was your question. Yeah. Washington County is the closest one that has hit my radar.
we looked at as many examples as we could, Chippewa, and Dunn County, and we haven't been able to find great financial examples like this one. This is probably the best one, most comparable one we could find. But the feedback we got is that they liked them, the employees liked them. So,
And I mean, again, it's all empirical and anecdotal, but most of them did say that they would continue the relationship from a financial perspective.
So I've got a couple questions.
Sure.
It's more than a couple, but so are the labs actually done with equipment in the clinic? Is that how we're able to save money, or do they
Yeah,
actually
so-
buy it at a deeper discount and just pass it on instead of marking it up?
So they buy the actual lab equipment to draw the labs in-house, and then they send it out to a processing facility. Probably a very similar processing facility that your hospital would send it to. I know a lot of our local access hospitals send them all to a centralized lab. And so they kind of get the actual supplies themselves is what they would pass back in cost. If you go and get the lab done at a hospital, you're not only paying for the supplies, but you're also paying for the nurse and the syringe and all the other stuff. So we get basically the cost of the test passed back to us.
Okay, so one big question is, what is the impact to those employees that choose not to utilize this type of service?
So the idea with an on-site clinic is for it to really kind of operate side by side to a certain degree. If an employee already has a dedicated primary care doctor that they really like, the idea is that this would kind of augment it. You'd have access to it, hopefully an after-hours clinic that you wouldn't normally have access to. You'd have access to low-cost labs that you could then provide to your primary care doctor. If you choose to not use the plan or not use the clinic, it would be just as we normally are. You would pay whatever copay or whatever deductible you are responsible for, and then that would be their responsibility.
And what kind of feedback, have we gotten any feedback from employees about this yet?
Yeah, so we did early in December, when we kind of started down this path, we did actually do a survey. So I provided kind of a high-level overview of kind of a very similar thing than what I just covered tonight. I provided kind of a concrete example of where I see the money savings, and we actually surveyed all of our staff. We had about 2/3 of our staff respond and provide their feedback. Some people, it was about 60% of our staff, again, not knowing any of the details, not me educating or anything like that, because it was just on a page worth of information. About 60% of them said that they would use a clinic, and then they also provide some additional details around if we were to do the clinic, like when would they want it open, what days would they want it open, that kind of thing. And there was also some open-ended comments of like, well, what are your general feelings about that? And again, so we took some of those into account. I mean, so we're all over the board. Some people say it's the greatest idea in the world. Some people say I'm never ever going to use it. Again, I think some of it is that 60% I see can probably go up once I have an opportunity to get in front of staff similar to you and again, kind of explain what it is, and even once we choose a vendor, get their kind of approach to care. I think that number can kind of tick up slightly.
And so this question is probably more for Ken, but it could be for you also. What does that mean for us budget-wise? So if we're committing all this money into this, because this is a lot of money, and then we have people that are still utilizing the classic policies and delivery of care that we've had in the past, where is that crossroads where if we only get like 300 people that do this or whatever it is, where is that fulcrum that makes this a total nightmare for us financially?
So we will project out what we expect the utilization to be. That will calculate the total budget for the health insurance plan. So the health insurance plan will have to cover all office or medical services provided offsite and the on-site clinic costs. So that's the total cost for the health insurance plan, and the premiums will be derived based upon that.
So is there a way for us, I don't know what the rules and the regulations allow us to do as far as incentivizing, not incentivizing, this plan, but guess what? This plan's going to be $10,000 a month for you as a premium. Like, don't quote me on that. I'm not saying that's a policy I want to implement, but I'm saying, just to be facetious, are we able to make it so that this is the choice for our employees?
Yeah, so that's part of the conversation when we go, as we go over here in the next kind of couple of months. I mean, we don't know, we kind of don't know over what our claims are going to be for next year, because that's really a big driver as far as what the premiums are and things like that. But to answer your question, yeah, we do have a couple of levers we can pull from a health insurance plan design. Say raising copays on the traditional plan would be one lever that we could encourage usage to there. We also have about $150,000 that are currently being used towards wellness dollars that we could earmark or adjust how we are using those dollars, again, to incentivize that utilization in that clinic.
Okay, cool. And then you had mentioned 71% of the ER visits could have been avoided with either urgent care or after-hour care instead of ER. What was the exact dollar amount that
I'd
equated
have to look. I don't have that one in front
Could
of me.
you email that to me?
Yep, I can send that.
That'd be awesome. And then just a couple others. What about natural or non-Western medicine care that a lot of people are starting to seek out? I mean, there's a huge boom in chiro, naturopath. How does that play into this?
So, and I actually had this question, one of our employees actually asked this question to me directly, and I actually went to one of our vendors who, and the doctor who actually oversaw the whole kind of rollout of their program. And I don't necessarily know that they're going to dabble in some of the homeopathic, but again, their approach is still all about overall patient wellness. So, but it's still rooted in science. Is kind of the response that I got. So again, they want to focus on making sure that the employee or the person, the patient, is well cared for and is on the right treatment paths for what they need. Again, some of that might be chiropractic care. They may refer out for chiropractic care, but ultimately, as long as it's rooted in science, it will be included as part of the treatment plans that are offered.
Sheboygan County that we looked at, their model is it's the county, it's the city, and it's the school district are all combined together. But they actually have a chiropractor in their clinic. So we won't, because that's costs us more money, but that is a possibility.
Are there any other questions? Yes, Supervisor Fiedler.
First of all, thanks for an excellent presentation. Do you say leaf or leaf?
Leaf.
Leaf, okay, got it.
Yep.
Just a couple of questions, but one kind of directed to Ken, following up on the chairman's question on cost. There's ongoing cost, but you mentioned an initial cost of about $500,000 to $1.2 million or $3 million. Can we afford it?
Yes. You can afford anything you want. You can't afford everything you want.
Now, as I semi-recall some of our earlier comments, given our actions we took at our last board meeting, or may take at a future board meeting with regard to certain contracts that are coming up, you may or may not have the very bare minimum of excess revenue to cover this. Is that generally a correct statement?
Yeah, what I'm thinking is, if this is a project that you guys want to do, and I need to keep the health insurance premium rate reasonable, because the county pays 90% of the premium. So a premium increase, while it affects the employees, it affects the county a lot more, because we're picking up 90% of it. So I need to make sure that that stays reasonable. We burned through $1 million of fund balance in the health insurance last year. So because of that, and if the clinic goes forward, what I'm going to propose to you is to move $1.5 million of general fund balance to the health insurance fund. That replenishes the $1 million that we lost, and it provides the $500,000 that I think we'll lose in the first year with the on-site clinic. So that gives me the cushion that I need to make this happen. And I believe that we'll have that amount available out of the 23 financials.
Just to keep, I have several follow-ups on it. So let's say you did that. Roughly in the percentages, what does that bring down our balance to? 41%, 42%? If you were to do that, or is it under 40% at that point?
So the financials for 2023 are unaudited at this point, so I don't know what I don't know. I don't know what adjustments the auditors might make or what they might find within the financials. Are they going to find anything, Dustin? I don't know. So So I don't know, but my preliminary projection shows that we will have probably twice that amount available to us in excess of our policy. So I think it's using only part of what's going to be available for us. And we will actually have to make that decision before the audit is finalized, but I think we'll be safe to do so and still be within compliance of our fund policy.
Yeah, because we'll also have some very major expenses coming in on the KIP and other projects, other hopeful tax savings, things that we do, and other things. I think we can accomplish all those things with current excess unassigned balance in that fund.
Anything, but not everything.
Yeah. So we have to just think about that too as a committee, that there's a lot of things we would all like to do, but maybe they won't all be possible. Also, okay, a second question. On size, you mentioned 1,900 square feet. That's pretty big. I look at this room. This is about 1,900 square feet, isn't it? Give or take?
This is probably closer to 1,000. It's probably a 30 by 30 room.
I think it's bigger than 30 by 30. But
I can count the tiles.
anyway, so, but you're saying if it was 1,000, this clinic would be twice as big as this room?
Yeah, and Leaf can address that question.
Yeah, and with the vendors that we worked with, actually with the on-site vendor, they actually for our size would have preferred a 2,200 square foot.
Well, they probably want the
but
Taj
that's what
Mahal,
we got.
but that's what,
That's what we got. So it seems to be in alignment with what they would need to support our additional with our staff.
It's unimaginable to me that we'd need a room twice as big as this. I mean, this is huge. I mean, I just think about, and I guess my next question was going to, would we see any savings from the, quote, clinic that's in the sheriff's department? For example, could we use this new facility to assist and work with the prisoners and save money from the sheriff's department by not paying that vendor?
Yeah, we've looked into that, and that has some potential, but also some real challenges.
I understand it
involved
have
in
some
But
challenges,
Yes, we've
but-
actually thought of that idea and have tried to investigate that also. And this room is 24 by 30.
24 by 30?
Yep,
So this is under,
under,
not,
yeah.
let's say 800? So you're talking,
Oh, 2,400 square feet.
yeah, that's what I was saying. So the clinic would be
Oh, I thought you said it was
slightly,
24 by 30.
be slightly smaller than this room. You
Yeah.
take off the dais, that would basically be.
Yeah,
what
and that was the
clinic would
size
be.
that the vendors, though, estimated for us.
Yeah,
was-
because there's got to be, if you think about when you
Waiting
have
area.
a clinic, there's going to be multiple rooms because they can't just have one room. They got to have a waiting room. They got to have office space for the doctors and nurses and things like that. So there's several rooms that would need to be fit into that space. So that's why, and that's where, like I said, the ones that have run the clinic, they have it based upon the number of people that need to go through the clinic. And that's why, again, they said for our size, for our 1,400 lives, they said they would prefer to have about 22 to 2,400 square feet. And we said, well, can you work with 19? Because that's what we got. And they said, yeah, we can work with that.
So the next question would be, how does all this relate to the space we're talking about with probation?
Unrelated.
No, so the
This
space,
space is carved off. It has a separate exterior entrance in between the jail
and
door and the
it's
sheriff's door.
it's downstairs too.
It's downstairs.
And the
So
probation
coming
would be
from
on the
lower
second
parking
floor.
lot.
Probation would be on second floor.
Yeah, probation's on the, yeah.
Okay,
on the
so
floor
so
above
that's
that.
ongoing, wouldn't have any impact on this at all.
Right, no
How
impact.
about anything dealing with the EDC? Have we talked about them renting any small space that might offset costs?
No,
Would
we
it be
haven't
worth
talked
it to
about
us to
that.
do? Would it be worth it? They don't pay much now anyway, so we wouldn't be talking about more than max $20,000. But they only had about 150 square feet in the past, so we're talking about a pittance of space. It's about the size of,
Yeah, you know,
one of
the
the
space
offices.
that we built, we framed it out because we knew that an on-site clinic was a possibility, and the cheapest time to do it was when we were doing this building. So we put the frame there. We have several ideas. If it's not an on-site clinic, it could be an employee fitness area, exterior entrance. It could be an exterior group meeting room. The Hudson Soccer Association was always looking for space where they could come in and they could meet in a space. It could be a pickleball court, as Supervisor Otino has requested. So there's lots of different ideas that we could put in there. It has low ceilings, though, so we would actually have to call it extreme pickleball. But It would actually fit a pickleball court.
I think he should think back of Aaron Rodgers and Bernhard Longer when he thinks about a pickleball court for old people. But orthopedic surgeons love pickleball. All kinds of broken arms, ankles, wrists, and fingers. Anyway, that's it. Thank you. Great presentation.
Okay, Supervisor Shirley?
So I think there's 2 or 3 major things that we have to figure out if this is really going to work. One, we have a large number of employees that are in Richmond and Baldwin, and if they don't buy off on this, then I don't see it happening and working well. So, in reality, if you're in Richmond and you live in Richmond and work at the Richmond facility, are you going to go to urgent care at Hudson Medical? It's right there, or are you going to drive down here?
Yep. And so that's something we need to talk about. As far as if you live in New Richmond, again, 20 minutes is not, I don't think that's necessarily a super unreasonable drive. Where my challenge or my primary concern is with the group that lives north of New Richmond. That one we need to ideally find a solution for. And again, on our near site model, they have said that they would look at opening a limited hours facility in New Richmond to kind of help that particular group. For our highway staff, they do have access to the clinic in Menominee. So it would be, if you live east of Baldwin, it's 20 minutes to Menominee. If you live west of Baldwin, it's 20 minutes to Hudson. And so we do kind of have, at least for the onset or for the near site model, we do have a plan built in for that. And generally speaking, I have spoken with a number of folks at Highway. A lot of them are just very open to that idea, and they're willing to drive to Hudson. At least the folks that I had talked to.
The other thing would be the incentive on the employee, and it may or may not be a popular opinion, but I'll lay it out there. The only way, in my mind, to incentivize our employees to use this model versus another would be to initiate an HSA program where they would actually hit their pocketbook more, and they would see the difference and choose this versus the other.
Yep. Nope. I agree. That's one of the things we talked about. How we get people in the door. Again, as I kind of said, there's a number of different levers. One of them is tying the HSA dollars to it, and frankly, a lot of it is around education as well. Because we do already give people $500 if they're single and $1,000 if they're on the HSA. If they use this clinic, it becomes: do I spend $250 to go to a traditional clinic, or do I spend $10? There you go. And so I think there's a lot of, just even with education around that HSA plan and how the HSA could work with the on-site clinic, I think will help kind of drive people not only to the HSA but to also utilize the clinic.
Supervisor Counter?
A few things. First off, under the models that you're talking about, would you have to have established appointments, or would you be able to accept walk-ins too?
So they do, I believe. I'd have to double check it as far as their specific policy. I know they do reserve a number of same or next day appointments to make sure that folks can get in timely. I'm not sure if you walk in, if you can get the clinic, but you can call in, get an appointment for that same or next day. They, especially with their near site model, they reserve, they already said they reserve like 25% of their appointments for those same and next day appointments, I think is what they said. I'd have to double check with them. But both of the providers said that they make sure that there is capacity for same and next day appointments.
I think one of the keys to making this successful is that it would have to get a high demand use. Get as much participation as possible. And if you considered also things like working with county membership, where our county employees, where you'd be able to set up through this clinic a phone visits for care and follow-up and coaching for things like diabetic and weight loss and those type of programs where they would get call-ins and have them participate and get them enrolled so that they would have annual physicals and things that would help. The more you can get people involved in taking care of themselves in healthcare, the healthier they are, the less we have people that are off of work because of medical reasons and everything else. So the more we can, be on top of this, the better off I think it is for the county. And so for that reason, I would be in support of this if there was a way to make it work financially.
Yeah. And I'll just speak a little bit to that as well. And I kind of alluded to it when I was presenting. But again, the approach of both of these vendors is always patient focused. And as I said, their appointments are as long as they need them to be. So it's not what the insurance company is going to bill, because insurance company will bill 15 to 30 minutes, 30 to 45 minutes. And so the goal is to make sure that before that patient leaves the room, that they are educated, they understand, and they know what their next steps are. And again, that is one of the key pieces around chronic disease management, that both of the vendors independently of themselves said that that's where they can help drive down those claims costs, because the more education that staff and staff members' families have on the various conditions, the more educated they are, the better off their health is going to be long term. And again, that's all about the focus shifting from that insurance company, how that's going to be billed, to patient-focused care.
Supervisor Shirley?
The other idea I was thinking about, going back to New Richmond and our Baldwin employees, is that if each one of those places had a small space that they could use as a virtual appointment area, that we could, use for some of the preventative and whatever that they didn't actually have to come in for, and try to push that more in those locations. Then our employees that work on cubicles or whatever else, they're not going to want to make their calls there where everybody can hear them. Maybe there's some place we can do that.
Yeah, and thankfully both of the two vendors do offer virtual, but that's a good point of giving people a space to do it. And we did actually even look at, up in the services center, is there a way we could even use existing space up there to even have a makeshift clinic for a couple hours? That didn't really pan out. We still don't. We looked at up at New Richmond, and this screening room that was just created, but there's evidently high demand in that particular room. But yes, that's a great idea. I don't know that we brought that up.
Administrator Witt, are you looking for action from us today on this?
It's not an action item, it's a discussion item, but I'm looking for feedback, head nods, head shakes.
I'm sorry, Supervisor Long.
Thank you for addressing the HSA question, because that's the one that I was most concerned about. Of the two models that you described, is there either the one that you are really leaning towards, and for what reason?
You're going to put me on the spot here. Personally, I think with the cost and the existing infrastructure, I would lean towards the near-site clinic, because that automatically has that Menominee facility that would be available for Baldwin. That's just my own personal opinion. I think having the existing infrastructure is going for something that we haven't done before, I think would be really helpful to have that kind of expertise there, to make sure that as they kind of guide us through the process to kind of get this clinic up and running. I just think having that existing infrastructure in place is really helpful. At least that's my own personal opinion. But I also think the on-site clinic has its own value, because I can see savings. They have a specialty drug program, which I didn't necessarily mention, that immediately can save us $100,000. But again, it does come with a slightly higher price tag as well.
I'll just make a comment then. I think this is a really good idea from a long-term perspective. If we can find a way of stomaching some of the initial costs and getting it up and running for the first couple of years, but from a long-term standpoint, I think it's worthwhile, and we should at least continue to look into it, investigate. That's my comments, or you're looking for feedback.
Are there any objections to Ken continuing an or Administrator Witt in continuing investigating this? That what you're looking for? Looks like it. Yeah, Supervisor Shirley.
Just one quick question. On the near site one, if they're going to move into our facility, are we still building it out for them, or are they putting that cost?
We would build out for them and charge them a rent.
Okay, thank you.
Cool.
All right, I'm going to move up number 5 to the next item, resolution disbanding County Library Planning Committee. I should have done that right away, Barb, and I'm very sorry. I didn't. I apologize. So. Perfect, thank you, Barb. So Administrator Witt, I'll turn this over to you, number 5.
Yeah, it's a very simple resolution. It's just disbanding this committee, similar to what we had done with the Transit Commission a few years ago, looking at leaner, more efficient government. The committee hadn't met in 2.5 years. They're charged with one task, and that's to create a library plan every 4 years. And it comes to this committee as a resolution and then to the county board. So it's just an extra committee for that one step. So I was looking at streamlining.
Is there a motion to bring this resolution to the floor?
I would move to approve the resolution disbanding the County Library Planning Committee.
Okay, motion by Long. Is there a second? Seconded by Fiedler. Discussion. Any discussion? Supervisor Counter.
Well, just so I understand, currently we're in the process of trying to reestablish. Would that process then be banned, or would they then still forge ahead and then commit that process instead to the admin committee?
Yeah, ultimately it rests with the admin committee anyways. You're basically just delegating that task to a subcommittee. So we would probably create a new process that still involves the librarians of the county with input into that plan of library services, because a lot of the data is coming from them. And that's what they're doing now. They're actually meeting as a librarians group rather than as the planning committee, because I haven't seen any agendas for the planning committee. So whatever work they're doing as a group of librarians of the county. And that might be a better process anyways, rather than using just half of them. The County Library Planning Committee, the county board may establish, so that's what the statute says. So it's not required that the county have it, it's a may. And so you have a choice either way, and just because you disband it today doesn't mean that you couldn't reconstitute it in the future if there's a different issue that comes up. But really, our funding, we've been at 100% for over a decade now. We're very, very stable in our process for libraries, so I don't see anything changing. I look back at the last 10 to 15 years of library plans of service, and they're all pretty much identical, just with new data every year in them, so.
And Barb, we want you to know that this is not being disbanded because of you not calling a meeting or calling a meeting. So just be very well aware of that. So.
And I understand that. I know it's not protocol.
Yeah. If you want to come up to the microphone, I will give you an opportunity to speak. But just so you know, I might cut you off.
Oh, no.
Okay.
I'm not going to speak very long. And the official charge is, the main responsibility is the plan of library service. However, I want to point out, and I missed this in my original comments, though I thought about it on the way down here, that the Library Planning Committee is who also helped engage the Wi-Fi hotspots. That's one example. It also serves to act as a conduit between the County Board of Supervisors and the residents of the community and the library directors as to how they can benefit each other. It serves as that conduit, and that means by having the Library Planning Committee, it was an opportunity for supervisors. Hey, how can the libraries help us, and how can we help the libraries? So that's another role that the Library Planning Committee has filled and can fill. We meet regularly. So I just wanted to point that out, that the plan of service is not the only thing that the board did. So thank you for the time, Paul.
Yeah, thanks, Barb. Appreciate you. Okay, so is there any other discussion on this?
I'll just make a quick.
Yep, Supervisor Long.
I think that it's really important that we get input from all the libraries rather than just a couple on this committee. So I think there's still going to be a good process, or can still be a good process in place to make sure we're getting feedback from all the libraries without necessarily having the formality of the committee.
Any further discussion on this? Supervisor Fiedler.
Just a quick question, because I didn't quite understand it, but apparently we're on the verge of receiving a planning report in the next couple of weeks. And so whatever we do tonight, we may want to just be vague enough to be able to accept that report when it comes in and benefit from it. So I don't know if that I don't think that would require an amendment, but we would just say we do it whatever we're going to do, but we should be very pleased to accept that report and consider it in the future to assist us.
Any further discussion? Any further discussion? Hearing none, all those in favor of the resolution signify by saying aye. Aye. Any opposed? Motion is approved. Number 4, resolution establishing 2025 budget priorities. Administrator Witt.
Okay, so in the packet, I have drafted a resolution based upon what I heard you guys say at the Committee of the Whole meeting. And so there's 5 points to it. One is really addressing the sales tax to move that projection closer to what the actual numbers are, and maybe reducing the amount of cushion that we've built in there. Number 2 is related to the health insurance, which we've spent some time talking about now, and I have some ideas that will help us keep that on the lower end of the projections. Number 3 then was employee compensation, so keeping that in mind, funding that if we have the resources available to do so. 4 was inflationary expenses. You heard a lot of the department heads talk about inflation they have, and really for some of those you don't have a choice. If our water bill goes up, you pay the water bill. I mean, you don't have a choice whether you want to or not, you just do it. And then 5th one is the new positions that were requested outside of the referendum, and that's to carefully consider those and recommend those that are most important if we have the resources still available at that point on the list to do so. So did I capture the priorities in the order that you wanted them, or do you have any changes to it?
Supervisor Long.
Yeah, I think you did a good job of capturing the priorities. I thought it was interesting that they're labeled A, B, C, D, and E rather than 1, 2, 3, 4, 5. So, well, that's what had been done in the past because they were priorities. So number 1 took priority over 2, 3, and 4. But I like this. I think this is a better way to do it because obviously, like D, well, am I just, like you said, it's got to be number 1. That's a priority. But I like the way this was labeled rather than one priority over the other. So that's, I think, I'm trying to say it's a good thing.
Are you looking for a motion to bring this to the floor then?
Yeah, I'm looking forward to the county
the
board
table.
adopting this because we'll use this as guidance for the department heads then for them to draft their budget. So we're a little bit behind schedule because I waited till the election was over, and we got our new members seated, so yes.
Okay, I entertain a motion to approve this resolution. Yes, I mean to bring it to the table.
I will move to approve the resolution establishing the 2025 budget priorities.
Okay, there's a motion by Long and a second by Fiedler. Discussion on this. Supervisor Fiedler.
I have a question for the administrator. One, could you just briefly review the sales tax issue, where we've been, how we got to where we are today? That's question one, and I have a second question.
Yeah, so we've had a strategy in the past that we really shadow the state projection for sales tax. And we were sort of shadowing it by about $1 million behind what the state was estimating. We were staying that $1 million behind. We did it for two reasons. One is if there was a recession, which I'll point out in my financial report that you can see coming. If there's a recession and sales tax goes down, we don't end up with having a loss for the year because we have a built-in cushion. And then two, because we have that built-in cushion, we always end up with excess funds, and the county board likes reallocating those excess funds to the capital projects, to debt service, to other things. And so it's nice to have excess money and not be short money at the end of the year. And so that's why we've always shadowed that number. So those are the two reasons that we've done so. So the guidance that I received, that I heard from the county board, and it was split, it was very close, but to shrink that, to make that a smaller gap than the $1 million that we currently have.
And we did some of this last year in relationship to some of the positions that we were going to fund also, correct?
Yes.
So that they did not have to be part of the referendum.
Correct, yep. There was $600,000 added, taken from sales tax, an increase of the sales tax projection, and that funded 4 patrol deputies. We call that the burning amendment.
And so then you know what's coming next. My next question is, given the mix of all the things we've talked about and the impact of what you just said and what you said about the sales tax, and it's inhibiting us from later using a surplus for something else, I think I can say that probably all of us would like to vote for a tax cut in the way we've done in the past, where we've done that through debt service. Do we have enough money to have a reasonable cut again this year, given the budget proposal you've suggested?
You can do anything you want.
Well,
You just
last
can't
year,
do everything.
last year we had roughly a $500,000 cut, if I'm not mistaken? Or was it just 400,000?
I think it was 400,000, yes.
So let's say this year we wanted to do 500,000 in something we could identify, however we did it. And we've worked very closely with you in the past as to the most expedient, thoughtful way to do that. That gives you the most flexibility and we don't do something rash.
Yep.
But let's say we wanted to do $500,000 this year. Can we do it?
You can do
I mean, we can do
anything you
anything,
want.
but is it reasonable, when would you suggest we make a motion to that effect? But I think we need to work closely with you so we don't do something irrational.
Yeah.
So we might want to postpone doing something like that, approve something tonight, but work with you on something like that in the future. Is that a good process?
Yeah, absolutely. So this establishing the budget priorities is really mostly looking at the expenses. You know, where are we going to allocate new monies that we have for the expenses? That item is going to come up in August when we get our audit report. You're going to see the actual numbers. And then in September, we generally introduce the resolution to reallocate. And that's still in enough time to affect the budget.
Perfect, thank you.
Any further discussion? Any further discussion? Hearing none, all those in favor of the resolution signify by saying aye. Aye. Any opposed? The resolution passes. Number 6, financial reports.
Yeah, the financial reports in the packet, there are just a couple of things that I wanted to point out to you. Yep. And I will make this very quick. So on this page, it's page 55 of the packet. what I wanted to show you here was vehicle registration fees went from 87 to 118,000. That's the new vehicle registration fee kicking in. So you can see that it was received in April, our first increased payment there. And then on the sales tax projection, what we received in April was 581,000. If you look back at the last 3 years, that's the lowest monthly collection we've had in over 3 years. So those are economic indicators. And so you can see that it is decreased maybe from what we've seen. Maybe it's an outlier month and things will go back up, but it might not be. It might be a trend. So that's where we're going to watch it, though, and that's your economic indicator for St. Croix County. I'd entertain any other questions, though, you had on the financial report. There wasn't anything else I needed to point out for you, though.
Supervisor Long.
Quick question on the very first page. There were two very large red numbers, but one was, last year's was much larger than this year's, so I'm assuming that that's a good thing, even though it's a negative $8 million. This is on page 31, sorry. The bottom report totals.
So you're looking at that $10 million number there.
And the $8 million.
There was, it's the debt. So the debt revenue. So the payment hit March. So it looks like a really big.
Supervisor Fiedler.
I'd like to just go back to the administrator's comment on the sales tax. From what quick math, it says we had a 20% shortage from where we've been.
Correct.
And our cushion had been 10%, had been, and now it's less than that. So we're looking at a 20% shortage and very little cushion. Am I looking at this correctly?
Yeah, but we're 2 months in.
Well,
so-
2 months in, but
Yep.
you pointed out that might be a trend.
Yeah, if it is a trend, that's where we're going to watch it, though. So I'm pointing it out because that's an area to watch now. So there's a red flag that went off, so we're going to continue to watch that as the year goes on.
If the trend continued, we're looking at $1.5 million deficit.
Yeah. That's why we have a fund balance, though, of 35%. So we can absorb that if that happens. And again, you want that to be an anomaly and not a every year trend.
But we've never had that in the last decade.
Yep, I have never seen that here in St. Croix County. We've always continued onward and upward.
Any further discussion? Supervisor Counter.
Just a quick thing, as I was going through it, I also noticed that it seemed like a lot of the subscriptions and stuff for software continue to rise astronomically, like more than medical expenses.
Yeah.
Are we kind of watching? Is there a way to kind of watch? I realize that you kind of get trapped into a lot of these companies, but is there any options that can be looked at for those types of things?
To a large degree, no. So like Microsoft products, there isn't an alternative to Microsoft. I mean, you're going to buy the Microsoft product and you're going to pay what they tell you to pay. Like with the Oracle system, we do negotiate and we look at the modules and the number of licenses, and the IT department does a good job of negotiating those down as low as possible. So where we can negotiate, we do. Some of them, there's really just not a lot of flexibility on. And really, it's Oracle that's driving it, it's Microsoft that's driving it, and it's the software that the sheriff's department bought a couple years ago. That one's really driving it. And again, they lock you in with a low purchase price, and then they've just been walloping us with the annual renewal cost.
Any further discussion? Okay, with that, request for future agenda items, Supervisor Fiedler, yours was noted for the $500,000 to look at that. Any other future agenda items that are requested at this time? Okay, seeing none, announcements and correspondence. Is there anything to announce or correspond? No, hearing none. All business items being met, I call the meeting adjourned at 6:20 p.m. And the next meeting will be the third Tuesday of June 18th, I think. Okay, thanks, everyone.